kidneys are very important organs. The functional units of the kidneys are the nephrons, and we have millions of these in each kidney. The nephron, the kidneys, are important in forming urine, and there are four main steps in urine formation. These are filtration, reabsorption, secretion, and excretion. In this video, we will focus mainly on reabsorption and secretion. It's important to understand some terminology though. Reabsorption refers to the movement of water and solutes from the nephron back into circulation. Secretion is the movement of solutes and stuff from circulation back into the nephron, back inside the nephron tubule. So let's just recap some anatomy first. Here you have the nephron. The afferent arteriole brings in blood, brings in plasma to the head of the nephron, where the vessels here will form what's called the glomerulus. The vessels will then exit the head of the nephron via the efferent arteriole. The efferent arteriole will then form the vasa recta, which are basically capillaries which will follow the tube of the nephron. The vasa recta allow for reabsorption of things back into circulation, while at the same time allow for secretion of things from the circulation back inside the nephron tubule. Now the tubule of the nephron has a few sections. After the head of the nephron, called the Bowman's capsule, you have the proximal convoluted tubules, the loop of Henle, the distal convoluted tubules, and then the collecting duct. These different segments or sections of the nephron are responsible for the reabsorption of different electrolytes and substances, as well as water, but also these different segments of the nephron may absorb the same things but in varying amounts. So let's focus on the reabsorption of things first, beginning with the proximal convoluted tubules. Here you get reabsorption of sodium, chloride, potassium, glucose, amino acids, which are the protein building units, urea, and bicarbonate, as well as water, of course. In the descending limb of the loop of Henle, water reabsorption takes place. In the ascending limb of the loop of Henle, so the going up part, sodium, chloride, and potassium reabsorption occurs. The loop of Henle here has a descending limb and it is ascending limb, as we talked about. The distal convoluted tubules are responsible for the reabsorption of sodium, chloride, potassium, calcium, magnesium, and bicarbonate. The collecting duct here is responsible for the reabsorption of sodium, chloride, urea, and water. Now, different segments of the nephrons also allow for the secretion of things back inside the tubule from the circulation, specifically from the vasa recta. Now, the proximal convoluted tubule allow for the secretion of creatinine, certain drugs, as well as hydrogen ions, which are, if you remember, these guys are the acidic ones. And the distal convoluted tubule allow for the secretion of hydrogen ions as well as potassium. In the distal convoluted tubule, there's actually an important transporter, which is actually responsible for the exchange of sodium and potassium. And this is how the potassium enters the tubule of the nephron. And this transporter is also a site where diuretics have an effect. Important things to take note here is that sodium and water play a key role in regulating our blood pressure. Bicarbonate and hydrogen ions play a key role in acid-base balance, so maintaining the pH of our body. So let us.
Diuretics are substances that increase production of urine. Most diuretics act to increase excretion of sodium, which is followed by water. Because increased urine production results in reduced blood volume, diuretics are commonly used to treat primary hypertension and edema. Changes in body fluid and electrolytes induced by diuretics can also be therapeutic for some other conditions. Sodium and water are filtered in the glomerular capsule of nephrons, then reabsorbed back to the blood at various sites along the renal tubule. Different classes of diuretics prevent sodium reabsorption and thus increase sodium loss at different sites by different mechanisms. Carbonic anhydrase inhibitors inhibit the enzyme carbonic anhydrase, which is required for reabsorption of bicarbonate in the proximal tubule. This leads to greater sodium loss in the form of sodium bicarbonate, and subsequently greater water loss in the urine. These inhibitors have the weakest diuretic effect because most of sodium lost at this early stage is reclaimed further down the renal tubule. Increased delivery of sodium to the collecting duct increases its reabsorption at this site through epithelial sodium channels in exchange for a greater potassium loss and may cause hypokalemia. Loss of bicarbonate also affects acid-base balance, producing metabolic acidosis. Carbonic anhydrase inhibitors are rarely prescribed for cardiovascular diseases. They are mainly used in the treatment of glaucoma. Osmotic diuretics, such as mannitol, promote water loss directly through osmosis. Being filtered without subsequent reabsorption, mannitol stays in the renal tubule, creating a higher osmolality which attracts water by osmosis. It produces a greater loss of water compared to sodium and potassium. Mannitol is not usually used to treat edema because its initial presence in the circulation may actually further increase blood volume to a dangerous level. It is, however, effective in lowering intracranial pressure in patients with head injury, as well as lowering intraocular pressure in acute glaucoma. Osmotic diuretics act on the entire renal tubule, with predominant effect on the proximal tubule and the descending loop of Henle. Loop diuretics inhibit the sodium-potassium chloride cotransporter in the thick ascending limb of the loop of Henle. These are very powerful diuretics because this transporter not only reabsorbs a large share of sodium, but is also responsible for the osmolarity gradient in the medulla that enables the collecting duct to concentrate urine. As the loop diuretics cause the salinity gradient to diminish, the collecting duct loses less water. More water is excreted in urine. Because the sodium-potassium chloride cotransporter acts in conjunction with back diffusion of potassium to create a positive lumen potential that drives reabsorption of other positive ions, its inhibition by loop diuretics also induces a greater loss of these ions. Side effects include electrolyte imbalances, metabolic alkalosis, hypovolemia due to excessive loss of water, loss of hearing due to inhibition of a similar transporter in the inner ear, and gout due to interference with transporters involved in urate secretion. Thiazide diuretics inhibit the sodium chloride cotransporter in the distal tubule, which reabsorbs about 5% of the sodium load, and are not as powerful as loop diuretics. However, thiazides also have a vasodilation effect by a still poorly understood mechanism. Thiazides are first-line drugs for uncomplicated hypertension and most effective for heart failure prevention. Unlike loop diuretics, thiazides reduce calcium loss in urine and can be used to prevent formation of new calcium kidney stones. This is because lower intracellular sodium induced by thiazides leads to higher calcium reabsorption mediated by sodium-calcium exchanger located on the basolateral membrane. Other side effects are similar to those of loop diuretics and include hypokalemia, metabolic alkalosis, and hyperuricemia. Potassium-sparing diuretics act mainly in the collecting duct. Here, sodium reabsorbs through epithelial sodium channels, ENAC, then sodium-potassium pump in exchange for potassium loss. Sodium influx into cells creates a negative lumen potential, which drives reabsorption of chloride and excretion of potassium and hydrogen. Both ENAC and sodium-potassium pump are induced by aldosterone. Potassium-sparing diuretics include aldosterone receptor antagonists and direct ENAC inhibitors. They are called potassium-sparing because they do not increase potassium loss, unlike all other diuretics acting upstream. Instead, they reduce potassium loss because reduced sodium reabsorption decreases the electrogenic exchange for potassium. Aldosterone antagonists also directly inhibit the sodium-potassium pump, reducing potassium loss. Because the collecting duct reabsorbs only a small amount of sodium, this class of drugs has only a mild diuretic effect. They are commonly used in conjunction with thiazide or loop diuretics to prevent hypokalemia. Side effects include hyperkalemia, metabolic acidosis, and effects associated with inhibition of aldosterone.
The next type of diuretics we will look at are the loop diuretics, and as the name might suggest, it works at the loop of Henle. Particularly, it works at the thick ascending limb of the loop of Henle. These are the drugs such as furosemide and bumetanide. Easy way is mide and nide. Loop diuretics works on the symptoma on the thick ascending limb of the loop of Henle and thus prevent the sodium reabsorption. Let's have a closer look. Here we have the blood and the tubular lumen. The tubular lumen is inside the nephron. Here we have the transporter, which is within the tubular of the lumen. So this transporter typically transports sodium, 2 chloride ions, and 1 potassium through. Loop diuretics prevents this chloride or inhibits this chloride from being reabsorbed and thus will basically screw up the transporter and not cause the other ions to be reabsorbed. In the long term, loop diuretics will also prevent the reabsorption of calcium and magnesium ions. So, loop diuretics prevents essentially the reabsorption of sodium, which therefore prevents the reabsorption of water, which therefore will decrease blood pressure. Some information. So loop diuretics will essentially increase the urine flow because it will prevent the reabsorption of all these things. It increases sodium, chloride, potassium, water, calcium, magnesium excretion in the nephron. And because it increases the excretion of these substances, it will therefore decrease the plasma volume, right? And thus, loop diuretics can actually induce renin release due to the plasma volume depletion. And renin, as you know, will want to increase blood pressure. For the absorption and elimination of loop diuretics, about 60 to 90% is absorbed when given orally, and the elimination is that it's secreted via the proximal tubule.